Welcome to the PD Exchange, the Peritoneal Dialysis podcast. I'm your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta, Edmonton, Canada. And with me is my co-host, Dr. Jeff Perl. Dr. Perl is a nephrologist at St. Michael's Hospital, University of Toronto, Canada. He is also editor-in-chief for Peritoneal Dialysis International. Today we are discussing the paper titled Dual SGLT1 SGLT2 inhibitor Phlorizin reduces glucose transport in experimental PD. It is published online right now. We are joined today by two eminent scientists to discuss this paper. Dr. Drs Oberg, he's a nephrologist and scientist at the Lund University in Sweden. He's particularly interested in the kinetic modeling of water solute transport across the peritoneal membrane. He is the senior author on this paper. And we have Professor Drs Fraser, who is a nephrologist and director of Wales Kidney Research Unit in Cardiff, Wales, UK. His research addresses the mechanisms underlying injury and scarring in the kidney and peritoneum in the context of CKD and PD. He also serves as the basic science editor of PD International. Welcome to the show, folks. Dr. Perl, take it away.
Thanks. I think we have a really exciting podcast. I just noticed that we're an all-male group today. The women in nephrology would call us a manel, not by design, completely by fluke today, given the authors and the associate editors today. I think that it's hard to go anywhere these days in nephrology and not hear SGLT2 inhibition raised within 5 minutes of a conversation as really game-changing medical therapy, slowing the advancement of chronic kidney disease, helping manage patients with advanced heart failure. And now delving into the peritoneal membrane, we're going to discuss some real important insights in terms of SGLT2 inhibition, glucose transport with the peritoneal membrane. And to me, this is very reminiscent of the 1990s when RAS blockade was the latest thing on the block to slow the progression of kidney disease. And all of a sudden, we realized there were important peritoneal protective effects of RAS inhibition in the peritoneal membrane, a so-called peritoneal-renal axis, as my colleague Dr. Joanne Bargman likes to put it. So we're here to talk about the peritoneal-renal axis of SGLT2 inhibition and glucose transport in the peritoneal membrane. We've had some really exciting papers, and it's such an honor to have Drs Oberg and Fraser, and Dr. Fraser, I just want to put a plug out for his role as the associate editor in PDI, handling all the basic science articles, really boldly going where many of us cannot go. And his expertise has been really instrumental to bring these to publication. So Donald, do you want to get the rest of us non-basic scientists up to speed on what we're here to talk about today?
Thanks, Jeff. I will do my best, but Carl will be the expert when it comes to this paper, and then several other papers from your lab, Carl, which have really thrown light on this area. It'll be very interesting to hear your views on this. I mean, it is tremendously exciting, isn't it? The paper that we're talking about today, this paper by Drs Bergling and Oberg, is an experimental study. So it's a study of SGLT2 inhibition in the peritoneum of rats. Before we get into that, as you've said, Jeff, these are drugs which are prescribed increasingly in nephrology patients with chronic kidney disease, and with ever lower GFRs, we're having to think about whether or not they should be started and whether they should be discontinued. So I think that's a question which is going to be recurring to peritoneal dialysis doctors and everybody looking after advanced CKD, people with advanced CKD. Just wanted to briefly, before we get into this, because it's going to be very important for the science, remind everybody about SGLT proteins. So there's SGLT2, which is the one we're mostly familiar with in the kidney, which is responsible for the bulk of renal glucose reabsorption in that very early segment of the proximal tubule. And then SGLT1, which has a role in the kidney, but it's a more minor role, a much bigger role in intestinal glucose absorption. And there've been a series of studies now, of which this is one, demonstrating, first of all, that these SGLT proteins are expressed in the peritoneum, and then secondly, that they're functional there. We know that water transport and ultrafiltration are critical to PD patients, so this is really important in terms of understanding how glucose is handled in the peritoneum and what we might be able to do to change that. This study is the use of a combined SGLT1/2 inhibitor called Phlorizin. That's a naturally occurring compound that comes from, I think, Carl, you can correct me, but apple bark and apple trees is the sort of the naturally occurring place where we see it. It's a derivative also of something called Phloretin, which is a related compound that has also been studied by your laboratories, I think we'll come on to. And in this study, what was done was to administer this versus control into animals with normal kidney function. And that's really important when we look at the data. And what was found, first of all, giving this intraperitoneally, was really marked changes in glycosuria, increased urinary output, and lowered plasma glucose. Those effects just showing the drugs getting in and affecting the kidney, I think. But then also an early reduction, so in the less than 60-minute window in peritoneal glucose transport. That's important because it tells us that the peritoneum is responding to this drug, which means presumably that SGLT1 and 2 have an action in the peritoneal membrane. Now, as we'll come on to, there are some other clues about this from other studies which may suggest more SGLT1 than 2, but maybe that's something we'll get into in the discussion. But the really important takeaway, I think, is that these drugs may have specific action, or drugs targeting this system may have specific action in the peritoneum, which is exciting in terms of specific therapy for peritoneal dialysis patients, I think. I don't know, Carl, if you want to jump in straight away with thoughts about that, the other papers in this area.
Yes, so we started out with a paper where we showed that inhibition of sodium glucose cotransporter 2 did not affect glucose transport during experimental PED. But as you mentioned, the study with Phlorizin, which is a dual blocker of sodium glucose cotransporter 1 and 2, reduced glucose diffusion. But there is an important detail here. Phlorizin is converted quite rapidly to a metabolite called Phloretin, and Phloretin is not an inhibitor of SGLT1 or 2, but actually facilitative glucose channels, GLUTs 1 to 4, for example. So the effects that we saw with Phlorizin could, of course, be due to inhibition of SGLT1, but they could also be due to effects by the Phlorizin metabolite Phloretin, which would mediate then the effects via GLUTs, facilitative glucose channels. So therefore, we did the study, the most recent study in JSON, using Phloretin, but also using a selective blocker of SGLT1 called misagliflozin.
Perhaps you should carry on and describe, because I was going to come to that JSON paper as well, which has had some important implications in terms of SGLT1, hasn't it? So maybe expand a bit and tell us about the other.
Yes, right. It's a selective blocker of SGLT1. So we tried that in the very same experimental model, and we saw no effect at all on water transport or glucose transport. Then in another group of animals, we instead tried intraperitoneal Phloretin treatment and found a marked improvement in ultrafiltration rate, more than 50% higher ultrafiltration rate in Phloretin treated animals, and also a reduction in glucose absorption by more than 30%. And in line with this, we also saw improvements in sodium transport and also a larger sodium dip, in line with the effects being mediated actually by an improved osmotic gradient, leading to a more pronounced sodium dip.
Carl, that's really fascinating. Quick question to clarify for our audience. The Phloretin was administered intraperitoneal, correct?
Yes.
And so what you said right at the beginning is that there could have been, it's really non-selective. It blocks multiple glucose channels, not just those that are sodium glucose channels. The other question I have was, I can't pronounce it either. Was that given intraperitoneal as well?
Yes, it was. So all drugs were given in the dialysis fluid.
Another interesting thing is that there have been some differences, haven't there, in terms of your own work? I think with empagliflozin previously not having an effect, and then in another study there was an apparent effect of empagliflozin, of course, a more SGLT2 specific drug. And I suppose one difference, there were other differences, but one difference there, I think, was that you administered intraperitoneally again in that other study, and then the other group, if I'm recalling it correctly, it was intravenous. Is that right?
Yes. So the first study we used intravenous gliflozin.
So I don't know if you think, I mean, I suppose the fact that you see such profound effects on renal handling suggests that the drug, when administered intraperitoneally, of course, is getting into the circulation, I suppose, and so maybe it would have the same effect. Or do you think that the intraperitoneal delivery is important in terms of affecting the peritoneum? Or
of course, if you give it intravenous, you have to give a much higher dose, and of course to get the same concentration in the dialysate. So that would be a drawback, because then you would expect systemic effects to be more pronounced than if you give the drug directly in the dialysis fluid.
So if this is again a naive from a non-basic scientist, do we know that these transporters exist in the peritoneal membrane because of staining studies? So do we know which ones are there? We just don't know their relative contribution to glucose handling. That's sort of the clinical question and the science question. Like we have staining studies that know that they're in the peritoneal membrane, correct?
That is correct.
We just don't know how they handle, to what degree they handle the glucose load and participate in glucose absorption across the peritoneal membrane.
Yes.
I would perhaps go a little further and say also, I believe that, for example, glucose administration upregulates these channels on the peritoneal membrane, doesn't it? So a peritoneum that's exposed to glucose, you start seeing much higher levels of expression of, and I don't know, Carl, if you have, from my memory of the literature, it's both GLUT and SGLT2 proteins are upregulated by glucose in the peritoneum, but I don't know if there's more nuance to it than that in terms of which ones are upregulated. But I do recall that the staining for both is up in a peritoneum that's seen glucose.
Yes, I have the same impression as you, but I don't remember exactly which orders were regulated.
Right. So now that there's a third dimension, that it's whether it's selective, and also dialysis vintage might modify the degree to which they are impacting glucose transport, because it's obviously a live membrane and there's changes in these over time. Maybe a question for you, Dr. Oberg. So the Phloretin story is really interesting. Are there, let's just say we want to use this as a therapeutic to block glucose absorption. Are there systemic concerns of Phloretin administration extraperitoneal that would be concerning in long-term use of Phloretin? If this became a therapeutic, for example. I know we're a ways away from that, but if we were blocking glucose absorption, would we have to be worried about effects on the kidney and in other organs on glucose handling?
So the experiments we did, we saw no renal effects actually with Phloretin, but with Phlorizin, we saw clear effects similar to those when administering an SGLT2 inhibitor with glucosuria. But you see no glucose increased glucose output in the urine when you give Phloretin. And we observed no other abnormalities in the animals treated with Phloretin. But of course, we don't know what the effects of Phloretin would be in PD patients. It's present in apples in quite large amounts, Phloretin. So an apple contains about 12 milligrams of Phloretin, but due to the low bioavailability, only about 1 to 2 milligrams of Phloretin will reach the circulation after consuming an apple.
So an apple a day might keep the glucose absorption away?
Possibly, you would need the
a lot of apples
of 8 apples per bag of dialysis fluid.
Yeah, we should not be telling our patients to eat 8 apples.
8 apples might be pushing it.
I think we found the title of the podcast.
Whether cider has the same effect, who can say? But
thank God it's low in potassium too, right?
Yeah. All I was going to say actually is, I think I think it was Phlorizin, wasn't it? Was the original sort of competitive inhibitor of SGLT2 and 2, and empagliflozin and canagliflozin and dapagliflozin are synthetic, as I understand it, but not so much derivatives, but at least compounds which are based on the same structure, I think. So I don't know if there are pharmacodynamic reasons why, these are, I think, weaker inhibitors, aren't they, than the drugs which we're more familiar with. And I suppose the other drugs which might be interesting in that would be the drugs with less specificity for SGLT2. So empagliflozin, for example, is highly SGLT2 specific, but sotagliflozin isn't. So there might be other drugs coming along which might have that kind of dual effect and therefore might be interesting to look at in the peritoneum. I don't know, Carl, if that's something that you would comment on in this.
Yes, so Phlorizin has effects on SGLT channels, but Phloretin has virtually no effects on SGLT channels, which is supported also by our data, showing that we get no glucosuria when we give Phloretin, but you get marked glucosuria when you give Phlorizin. So Phlorizin is also a dual SGLT channel inhibitor. The reason why Phlorizin was never used as an SGLT blocker in patients is the fact that Phlorizin is hydrolyzed to its metabolite, phlorid, in the intestine, and this conversion is nearly complete. So virtually no Phlorizin, if you give it orally, reaches the circulation. So it cannot be used as an SGLT blocker.
My other question to both of you, maybe Carl first, is what orders of, in the studies you saw, what orders of magnitude of blockade of glucose absorption are we talking about in terms of, what we're impacting? And again, a naive question from a non-basic scientist, is there any correlate to there's sodium glucose? So is there any correlate to potential impacts on sodium absorption or sodium handling of the peritoneal membrane? But let's start with the first question about sort of what we're talking about with these, how much glucose absorption are we reducing? Enough to make, do you think, a clinical difference?
So I think that the most important effect is the effect on ultrafiltration, where we see an improvement of more than 50%. And I would say that that's an effect that is clinically significant. The glucose absorption was reduced by about 30%. This is, of course, also quite a lot of glucose. If you consider that the average PD patient absorbs about 100 grams of glucose per day, it's almost a third of the glucose load.
Right. And I think it's fascinating because up until now, the only therapeutic we really had was, glucose polymers that obviously reduce the carbohydrate load and absorption. And, there's the sort of UF efficiency of UF per grams of carbohydrate absorbed. So I see really two really exciting stories evolve, one on the ultrafiltration side and impacting volume management in our patients. The other is the Achilles heel of PD has always been the use of glucose solutions and potential positive metabolic effects from, being able to get away with less glucose absorption and more ultrafiltration. So I think it's such an exciting story. And we, tell us what you think needs to be done next. Where are we going next without giving away all your secrets? Where do you think we need to go next with this story in terms of moving the field forward?
First, I think there is room for starting small pilot studies. You could, for example, use Phloretin, but you could also use another drug which has similar effects on blocking glucose channels. So I think that's a possibility to do such clinical studies. Experimentally, what we need to find out is, of course, which channel is responsible for the effects that we see, because Phloretin is a non-selective blocker. So we don't know exactly which channel it is.
And you said Phlorizin gets converted to Phloretin, correct?
Yes.
Is there anything that can block that or stabilize Phlorizin so we can study it specifically to avoid that? Like, can that compound be modified to block that metabolism so we can study its effects as well without worrying about the conversion?
Not that I know. So there is also this substance which Donald mentioned called sotagliflozin, which is a very potent dual inhibitor,
Right.
which you could also use to study dual SGLT blockade.
Okay. And again, which cells of the peritoneal membrane are we talking about for us non-basic scientists? Where is the action happening with glucose handling? Because as we know, we have the mesothelial cell layer, which in long-term patients may be lost, the submesothelial compact zone, and then we have the peritoneal capillary layer. So where are we talking about here for us non-basic scientists?
Should I
Or
answer
maybe we
that?
don't know.
I was going to ask you the same question actually. So I'd be really interested to hear that one, because in the studies I found it hard to see where you can see the staining, but where is it? Yeah.
Yes. So endothelial cells are rich in GLUT1 channels. So that we know, but also of course other glucose transporters. And then you have also in the interstitial tissue you have fibroblasts, which also express GLUT1, and there have been hypotheses that they may play a role in the intramembrane glucose gradient, which may be weakened by these fibroblasts, as I understand the hypothesis by Ray Credit, I think.
Yes.
So that's
Yeah,
a fascinating story that we'll need to understand a lot more of as well. What is the cell type that we're targeting? And maybe, again, that speaks to vintage, because one would expect in long-term vintage patients, there may be more of an enrichment of fibroblasts. And so maybe that handling changes over time by dialysis vintage. The other thing I'm just throwing into the pot here to confuse the story even more is we all know the aquaporin polymorphism story, right? That involved with the New England Journal paper with Johan Morell's work. There could be a similar story brewing here with genetic variation in glucose handling of the peritoneal membrane that might also explain some heterogeneity that we might observe across individuals. Do you guys want to comment on that?
I guess I don't know. I mean, the genetics could be really interesting. I'd agree with that, definitely. I haven't seen anything about genetics and SGLT, so that would be an interesting one if there is something there. I may have missed it if there is, but I can see those are genes that might be really important in that. The other thing is that yeah, I mean, and Carl was alluded to this just now, that the metabolism of glucose may be a really important driver of pathology in the peritoneal membrane as elsewhere, and these drugs or drugs that target glucose uptake, it may not just keep the glucose where we want it, but may also stop the glucose getting into cells where it drives pathology. So membrane change may be driven in part by the glucose, and inhibiting that may have important effects. And there has been some work with dapagliflozin, so Michael Balzer and Nelly Shishkova's work from 2020 showing mitigation of peritoneal fibrosis with dapagliflozin. I don't think they're the only group actually who've shown that. So there may be, the studies that we've been talking about so far have been quite, they're acute studies of glucose handling, but there may be effects with longer term inhibition as well that may go beyond keeping the glucose back, but also maybe stop some of the adverse consequences.
So now we're saying three potential benefits. One is prevention of glucose absorption and enhanced ultrafiltration. The second is the metabolic downstream consequence of the less glucose absorption. The third is modification of glucose handling at the level of the peritoneal membrane that might mediate some positive changes in terms of some of the progressive deleterious changes we see of the peritoneal membrane in terms of fibrosis and neovascularization that we know occur over time. That's really fascinating. And we haven't even talked about this whole other axis, which is the huge potential on preservation of residual kidney function. And so, we know that in the CKD population, at increasingly lower levels of GFR, there's evidence that's mounting that these drugs may be beneficial at slowing chronic kidney disease progression and also improve cardiovascular outcomes. That's a whole other sort of area that is, I'm sure, going to be looked at in the future in PD. And, thinking about the studies, from Lee and Suzuki that looked at RAS blockers and ARBs and residual kidney function, I would imagine similar studies would be done in the PD population to look at its impact on residual kidney function preservation, a whole other axis independent of what happens at the level of the peritoneal membrane. But of course, understanding that, these are selective glucose transport studies. And we've talked about, making that important designation for what impact there might be on glucose blockade at the level of the peritoneal membrane.
Yes, that's really interesting, Jeff. Phlorizin is of course converted to Phloretin in the peritoneum, but we saw also in these experiments that there were systemic effects and effects in the kidney reminiscent of those from SGLT2 blocker. So maybe Phlorizin is the most appropriate drug to use rather than Phloretin.
Okay, just a couple of quick questions that I have. Again, these are rapid fire, yes or no. We haven't talked about glucose degradation products and advanced glycosylation end products. Do these transporters at all mediate absorption of glucose degradation products at all? Or these are, they get in through a completely separate mechanism?
So age have receptors for age, don't they? And I think the answer would be a no from me. I don't know if Carl would agree with that. I'm not aware of any evidence that the SGLT proteins do that. I think glucose specific. So
I haven't seen any data on that, to be honest.
So we would affect, so in a low GDP, in the people who believe in and are users of low GDP neutral pH solutions, we wouldn't expect any differences in the efficacy of these compounds by glucose solution type. Any studies on codextrin and its impact on glucose GLT2 expression or glucose expression? Downregulate, upregulate, no difference? Have those studies exist?
I mean, I to my knowledge, the data that we have on the upregulation in response to glucose is experimental model rather than patient. So I think it would be really important and really interesting to know what happens in the peritoneum of patients exposed to so with dialysis registries, for example, the expression of SGLT2. I haven't seen that data. It would be really interesting to know that. I'm not sure if there's anything relevant to icodextrin. Certainly, I haven't seen it. If there is, I don't know, Carl. Maybe you know more than that.
No, I haven't seen any such data. I believe the hypothesis is that it's the high glucose concentrations that elicit more expression of glucose transporters. So theoretically, then icodextrin would have a lesser effect on transporter expression.
And my other question is for the financial. I know these are rapid fire all over the place, but for the financially concerned part of me, how expensive are these drugs? Are these expensive drugs or relatively inexpensive as we think about human studies?
So Phloretin is inexpensive because it comes from apples, and
right.
Phloretin is even less expensive. I think you can get several hundreds of grams for very little money of quite good purity.
That's really interesting. And then the other thing I'm thinking about, again, my wheels are turning here. We use a lot of APD for volume management, but maybe in the future we could make CAPD much more attractive, because essentially this kind of addresses one of the big fallacies of CAPD, which is the risks of glucose absorption during long dwells. So from a cost perspective, it might actually allow us to maintain more patients on CAPD, less use of solution, and lower dialysis costs, which of course is really important for emerging countries and low and middle income countries that are looking to start to use PD a little bit more. So there could be a real advantage there in terms of being able to shift things to greater use of CAPD.
Yes, so I mean, and less membrane damage means that patients can stay on therapy longer.
This is almost like a brave new frontier in the history of peritoneal dialysis. This particular group of experiments is so exciting because I think a lot will come out of it that will be immediately applicable and solve some of the key problems that we face every day in our clinic, both with fluid and membrane failure. So this is extremely exciting. When can I start using this again?
And Donald and Carl, it's really great to see such enthusiasm in basic science research in PD. A lot of us don't get exposed to it as much as we should, and it's great to see this kind of work evolving. And I really hope that at the ISPD meeting in 2024, we have a whole session devoted to glucose handling in the peritoneal membrane and these emerging insights, because this podcast, I think, just scratches the surface of what we know and what we need to know in terms of this. And I've learned so much. And I personally want to thank you guys both for your time and enlightening the PD community about this really emerging and exciting area of therapeutics for peritoneal dialysis.
Thank you so much. It's been a pleasure, really interesting discussion with all of you. And Carl, I want to congratulate your lab on some really, really important studies. So, read them all with great interest, and I'll be watching with interest to see what the next chapter is.
And remember, Peritoneal Dialysis International is a wonderful home for this evolving and advancing PD research.
So thank you so much, all of you, for coming together on the show and educating us about this really exciting aspect of peritoneal dialysis and sharing all your experience. We really look forward to future studies. And that's a wrap, folks, for today's episode. Link to the papers are in the episode details, and please reach out to us on social media or email for any comments and suggestions. Our Twitter handles and email IDs are in the episode details as well. Hope you enjoyed the show. This is Jeff and Nikhil signing off. Until the next PD exchange. Take care.